You can recognize overdiagnosis not because you can prove the diagnosis is wrong, but because you can prove the diagnosis is not benefiting people. Surely we should be able to look at children in schools and say, do you know what, this kid is not happy, or this kid is struggling, or this kid needs help, and not have to give them a medical label. And then with incredible speed, hashtag long COVID became a condition called long COVID, which entered the mouths of politicians, which then entered medical journals, mainstream media. But actually the most severe disabilities I see are psychosomatic.
Hello and welcome back to UnHerd. Eagle-eyed viewers might have noticed that UK Health Secretary Wes Streeting said this recently.
Mental well-being, illness, it's a spectrum, right? And
but you do think there's overdiagnosis?
I think there's an overdiagnosis.
Meanwhile, across the Atlantic, the Trump administration's return has brought Robert F. Kennedy Jr., someone we've discussed a lot on this channel, as US Health Secretary, promising with Make America Healthy Again a disruptive overhaul of public health. And this coming week, Dr. Jay Bhattacharya, a friend of the show, will probably be confirmed as the new director of the National Institute of Health following his Senate confirmation hearing earlier this month. We've got an exclusive video with our own Freddie Sayers that we'll release as that happens, so do check it out soon. Could these shifts signal a broader reckoning with how we define illness? Here to unpack it is Dr. Suzanne O'Sullivan, a neurologist with over 25 years of experience, now based at London's National Hospital for Neurology and Neurosurgery. She's the author of many best-selling books, including It's All in Your Head. We're here to talk about her extremely timely new book, The Age of Diagnosis, which challenges our rush to label conditions like ADHD and long COVID and asks if we're over-medicalising normal human behaviour. So, welcome to UnHerd, Suzanne.
Thanks for having me.
So I've spoken to a few people on this channel. John Haidt comes to mind, Abigail Schreier, about the overdiagnosis of mental health conditions, whether that's depression or anxiety. That's what Wes Streeting was nodding to in that comment there that I mentioned in the introduction. But what you lay out in your book, The Age of Diagnosis, is something I suppose that might be more surprising to people, which is that there isn't simply an overdiagnosis problem in mental illness that can be, to some extent, self-diagnosed. You have to say, I feel depressed to get a diagnosis of depression. But that physical conditions, including even cancer, are being overdiagnosed across the board.
The first thing I want to do is just be clear on what I mean by overdiagnosis. So overdiagnosis doesn't necessarily mean a diagnosis is wrong. It just means that diagnosis isn't benefiting the person. The struggle may be real, but the medicalisation of it is not necessarily optimum. With regard to physical health, I mean, we've had these assumptions, and it applies to both mental and physical health. We've had these assumptions for a long time, and they sound good, which is where you say if you find a disease at a much earlier stage or in a much milder form, and you treat it, that you will promote long-term health, and that treatment for mild illness and disease is as beneficial as treatment for severe disease. Now, that all makes a lot of sense. But what that means in practical terms, so let's take a couple of examples like high blood pressure and pre-diabetes. So if you identify people with high blood pressure and intervene, you can potentially prevent strokes. So what the medical community does is it says, okay, the earlier we catch this blood pressure, the more strokes we can prevent. So it slowly adjusts down what it means to have high blood pressure. And there was a change at one point several years ago where they said one day high blood pressure is 140 over 90. The next day, high blood pressure is 130 over 80. So now everybody in this kind of borderline zone who was healthy on Monday is a patient on Tuesday. And some of those people will be helped because strokes will be prevented. But a much, much bigger group of those people will get treatment that they didn't need. So to prevent one stroke, you probably have to treat 80, 90, and that's being conservative. Could be much bigger number than that, who didn't need treatment. And that's what overdiagnosis is. You have to turn lots and lots of healthy people into patients to prevent one disease. And that's happening in all fields of medicine. Hypertension, diabetes, osteoporosis, renal failure. People have been adjusting the limits of normal to capture more patients. It helps a small number of people and medicalizes a big number. In terms of cancer, we have better and better tests for detecting cancer. The consequence of that is that we can now detect abnormal cells that would never have been detectable by us before. The difficulty is that lots of people have abnormal cells in their body that never grow. And we do not know the difference when we find abnormal cells between the ones that grow and don't grow. So every single one is called cancer and every single one is treated as cancer. But if you look at the statistics of screening programs for cancer, let's say if you screen 2,000 women for breast cancer, you will save 1 life from breast cancer, and you will treat 10 women for abnormal cells that would never have progressed if left alone. So it's just because we're getting so good at detecting disease, and we are changing these parameters between normal and abnormal to be oversensitive. We are treating too many people to save small numbers of people.
To take a kind of devil's advocate position here, you might say, well, look, if people are having any sort of abnormality detected and then they're receiving treatment, even if the treatment is effectively unnecessary, what's the problem there? Could treatment ever be bad?
Well, that's exactly the sort of thinking that has driven this problem forward, is everyone thinks, well, let's say you're diagnosed with hypertension and you're not one of the people who's going to get stroke. Let's say there's 100 people and they're not going to get a stroke, but they've been given advice. And everyone thinks that, well, that's fine, no harm has been done. Immense harm has potentially been done to those people. First of all, you've got the psychological impact of telling a healthy person that they're a patient. That immediately changes a person's relationship with their body. It causes health anxiety. It affects a person's mental health. You are potentially expose them to treatment that they didn't need, with all the side effects and potential problems that come with that. There's higher work absenteeism for people who have been labelled with a disease. So it affects people socially, psychologically, financially, when you tell them that they have a medical problem. And that's something that just isn't measured. There's always this assumption that it's kind of these overtreated people are doing okay. But actually nobody's looking at those overtreated people to see if they are doing okay.
That's not even to mention the fact that some, cures for cancer that have been proven, if they're given to someone who doesn't have cancer, could cause cancer.
Well, this is a really important point. So we are assuming that all these screening programs for cancer are saving lots of lives. And that can look like that is the case if you look at the figures in a certain way. So if you treat lots of people for abnormal cells that were never going to progress, and then they survive and they don't get cancer, you kind of say to yourself, well, that treatment worked. My cancer treatment is really successful. But if you look at these populations differently, so you look at a large screened population who got cancer, and you look at cancer deaths, you can say, okay, fewer of these people died from cancer. But if you look at a thing called all-cause mortality, so that means death for any reason, you find that actually you haven't prevented any deaths in this group. And probably what has happened is that you have saved some lives from cancer, but you have had a detrimental effect on the health of other people through your cancer treatment. So some people are being helped and some people are being harmed, and the overall effect is no lives have actually been saved.
And then there's the psychological impact that you mentioned there briefly, the idea of being a patient or being medicalised. I mean, I hear it a lot around people I know, the idea of kind of perimenopause, pre-diabetes, these pre-illness conditions in which you have not yet got the condition, but you are living in fear of the condition effectively.
Yeah. I mean, when I wrote The Age of Diagnosis, I started with a case that I know will affect almost very few people. So they won't have a personal experience of it, but it speaks to the problem that you're talking about. So I started with a woman who learned that she had a family history of Huntington's disease. Now, Huntington's disease is a very serious neurodegenerative condition. You can have a genetic test for it that tells you you're going to get the problem years ahead of time. And this particular woman learned it was in the family, and simply learning that she was at risk of this disease made her extremely symptomatic. She began searching her body for symptoms. So she was worried that she would get Huntington's, and she knows Huntington's caused personality change, mood problems, loss of balance. So listen, we all trip over things some days. We all bump into things. We all forget things. But when these ordinary things happened to this particular woman, she thought they were beginning of Huntington's. So she paid attention to them. That reinforced them. That made her more disabled. It made her more anxious. She paid more attention to her body, and everything got worse. Now, as it happened for this particular lady, when she ultimately tested for Huntington's disease, she didn't have the gene. So ultimately what this had happened to this lady is exactly the problem that you're expressing, which is that believing that she had Huntington's disease focused her on her body and produced symptoms out of nowhere. And that's the problem. Well, nowhere is really the wrong word there, actually. It produced symptoms out of her anxiety about developing a disease. And the same sort of thing is going to happen if you tell someone they're at risk of diabetes, then everything that happens to them could potentially be framed through that anxiety. If you tell somebody that they're going to develop dementia in X number of years, and every time they forget something, they'll believe it's the beginning of dementia. So we shouldn't underestimate the risk of telling somebody that they have an impending disease. It can alter their entire experience of their health.
Okay, again, to play devil's advocate though, isn't there an argument here that, for example, for someone who's pre-diabetic, that a change in behaviour that comes after that anxiety might actually stop them having that disease eventually, or at least alleviate some of the harsher symptoms of that disease?
I mean, you're precisely right, and that's the reason they have these kind of screening programs, is because that is the premise on which they are made. However, once again, I think the limits are set so generously. So there was a change in the definition of what prediabetes is some years ago. And if every single person in China was tested according to those new criteria, 50% of adults would have diabetes. A third of people in the UK would have diabetes by those criteria. So again, we're in that situation where we're labeling a huge number of people of having a pre-disease. Only a percentage of those people will actually develop the disease, and the rest of the people are being labeled unnecessarily. It's really a kind of an issue of economics. You know, how many people are you happy to turn into patients unnecessarily to save one person? And I feel like we are not giving enough thought to the economics of that. You know, we're very relaxed about all those people that we're medicalising because we're very satisfied with the person we've saved. It's time to pay a little bit of attention to the medicalised people.
The complaint many people have about the NHS is quite the opposite. Not that they are overdiagnosed or overtreated, but rather that they are deeply undertreated, underdiagnosed. What do you say to those people who suggest that the NHS is in fact not doing enough for patients, rather than, as you say, doing too much for some?
Well, I think they're absolutely right. You know, we've got, on the one hand, we have people being neglected. You can't get an appointment with your GP, or you're waiting a year to be seen in hospital. So on the one hand, we have people with symptomatic disease or illness who need to see somebody, and the waiting lists are too long and they're being neglected. On the other hand, we're inviting healthy people in for tests that aren't necessarily going to benefit them. So there's no doubt in my mind that people are being neglected, and I absolutely sympathise with those people. We need to think more about what I would call low-value care. So screening huge numbers of people for illness that will only benefit a small number of people is low-value care. Screening is very important, but what we should perhaps do differently is recognise high-risk people. So let's say screening. Do you know who goes for screening? White, middle-class, wealthy, educated people who are already motivated to look after their health. And you know who doesn't go for screening or doesn't follow the advice on screening are people who lived in deprived areas, who have less time and less awareness in this area. So what we should be doing is screening high-risk people. That then screening becomes high-value care and reserves some resources for the things that we all care about, which is getting appointments with our GP. It's terrible to turn on the news and hear that somebody with advanced cancer cannot get a cancer treatment that could perhaps prolong their lives, and then be simultaneously aware that there's a lot of medicalisation of ordinary aspects of our life and resources wasted in that area. I think it's also important for people to understand what good medicine looks like. So I think we have a little bit of an idea that good medicine looks like you go to your doctor, and if they've listened to you properly, they'll send you for the brain scan to make sure you don't have a brain tumour, or they'll do the blood test to make sure everything is okay. That's not what good medicine looks like. Diagnoses are not made by machines, and they are not made by scanners or blood tests. Diagnoses are made by doctors or medical professionals, nurses, etc. And what good medicine looks like is you go to your doctor, you explain your symptom. If it's not immediately urgent, your doctor may say, well, let's watch and wait for a while, and then they'll see you again. So good medicine is being listened to, being heard, being seen for follow-up to make sure that things are improving. Good medicine isn't, if your doctor does a test the minute you go to them, then that's not what good medicine looks like.
Let's speak a little bit about autism, because that's an example where good medicine is definitely under question, because there is this idea of the autism spectrum, which is very distinct from someone who has cancerous cells or doesn't have cancerous cells, though of course there's arguments about these kind of precancerous cells that I suppose does fall onto some degree of spectrum. But with autism at least, the spectrum is now so wide that an autism diagnosis can cover everything from someone who's completely non-verbal and unable to engage in everyday life without a lot of help and support, to somebody who has a need for a stimming toy in their school life. What's happened with autism recently? Why is there such an explosion in diagnosis?
Part of it was a correction of an under kind of diagnosis chronic neglect problem. You know, I was in school in the 70s and 80s, and nobody was recognized as having special learning needs, in a class of 120. Clearly, there must have been young people who would have benefited from getting support. So we have a history of neglect that we needed to correct. Autism started as a concept in the 1940s, and it was described as extreme autism, aloneness in children who had no more interest in people than they would in a bookshelf or a filing cabinet. So that's the concept as it started, severely disabled people. Then in the 1960s, somebody examining children attending mental health services in South London noticed that these autistic traits were present in less severely disabled children. So they said, hey, maybe this is a spectrum. And again, this is so well-intentioned, because now they're saying, these problems can come in milder forms, and maybe we help the milder people, they won't develop the mental health problems. But after that, the criteria for diagnosis of autism just kept relaxing and relaxing and relaxing. So you used to have obvious autistic traits before the age of 18 months. Now you can almost have no traits into adulthood and still get the diagnosis.
A late stage autism diagnosis, which is now what we hear a lot of.
Yeah, so over the recent decades, as the criteria have it's all well-intentioned. Someone says one day, do you know what, I don't think enough women are getting an autism diagnosis. Maybe they're being missed, and maybe we could help women. And they say, well, women aren't really exhibiting this feature of aloneness because young girls tend to be more sociable than boys. So then somebody says, okay, if we want to make the diagnosis of autism in these people, we need to think about girls differently. So let's say it's not aloneness in girls. Instead, that maybe they have lots of friendships, but they're shallow friendships. Now you have completely changed the concept of what autism is, so that you can apply it to a new group, and then you've got lots more patients. It's done with good intention, but what rarely happens is what needs to happen, which is that the person people who are making these changes says, how are these girls going to benefit from this diagnosis? The point of all this relaxing of diagnostic criteria is to improve long-term mental health and to improve people's progression through life. If that was working, I would be perfectly happy for them to diagnose anybody with autism if it resulted in an actual improvement, what it's pretending to offer. But what we're seeing is we're having growing populations with autism, and we have a growing population with long-term mental health problems in adulthood and people dropping out of university. So these relaxation of diagnostic criteria made with good intentions. You can recognize overdiagnosis not because you can prove the diagnosis is wrong, but because you can prove the diagnosis is not benefiting people. Mm-hmm. And I would say that's very much the definition of not benefiting people.
So you can almost read into whether or not it's an overdiagnosis based on the reaction to the diagnosis, whether it's a relief or a burden, I suppose, whether it comes with benefits that would make life easier or whether in fact it hampers life further.
I mean, the difficulty with overdiagnosis in every field is if you say to somebody, you've been diagnosed with cancer, and then they're treated and they're fine, they will never know if they were overdiagnosed. And same with an individual with autism will often find, well, that explains a lot and I feel better. But the easiest way to spot overdiagnosis is you look at a population of people and see, are you making this population better with this expanded diagnosis? And I know that mental health has many different things playing into it, but if we've gone from 0 special accommodations in school to 27% of UK school children getting special accommodations because they have a mental health problem, and we are seeing no downstream improvement, then maybe it's time to stop and think, hey, we meant well, but it's not working.
And as that number grows, it makes complete sense that parents would seek out diagnosis, because if it confers some benefit in the educational setting, if you get extra time on exams or a specialist teacher who will help them with their homework, of course, any parent who sees a child that's struggling can reach for this particular diagnostic framework as a way of getting that help for their child. And whether or not the actual diagnosis is relevant doesn't really matter to them.
I mean, the difficulty is we've set up a system now, first where we have created the impression that special accommodations work, and I think there's reason to doubt that special accommodations work. There have been studies in Canada, for example, where they compared university students with ADHD who got special accommodations and ADHD students who didn't. And actually, although the ADHD students who got the special accommodations perceived that it helped them, there was no actual evidence that it helped them. And then what you're doing is you're suggesting to those young people that they need the extra help to get on in life. And that really creates, at some point, they're not going to get the extra help. So we're first of all kind of fooling people into thinking that it works when there's very little evidence it works. Secondly, we are requiring people to get a diagnosis if they want help for something. And that's the biggest problem for me. Surely we should be able to look at children in schools and say, do you know what, this kid is not happy, or this kid is struggling, or this kid needs help, and not have to give them a medical label. But we are requiring schools, if they want to get extra help in class from teaching assistants, etc., they need medical diagnosis. If parents want to get help for their kid, they need a medical diagnosis. We need a system of helping young people that doesn't rely upon labels.
So much of this seems to come downstream from an overcorrection as well. The overcorrection for the stigma that used to be associated with conditions like ADHD, OCD, anxiety, seems to be that now there are phrases bandied around like, autism is my superpower, which obviously I would say could only really apply to those on the very mild end of the spectrum of autism. If 100%. You've known anyone who's on the severe end of the spectrum, it certainly does not feel like a superpower and wouldn't to anyone around them. So where does this fit in, the kind of mental health positivity element, where it's you are obliged to be positive and reassuring about someone who receives one of these diagnoses, that in fact their life could be better with it than if they had simply tried to resist the various implications of that diagnosis?
I mean, it has implications for so many people, this sort of romanticized view of what a mental health illness is. I look after people with severe autism, and, it's such a devastating disorder for those families. But the voices of the severe or moderately severely affected people with mental health and learning problems and behavioral diagnoses are not represented on social media, where you see people celebrating being diagnosed. And I think that there's a real tone problem there. If you're celebrating being diagnosed, then there is a problem, because the concept of all of these diagnoses is they are supposed to be diagnosed because you have an impairment. So I understand that people kind of refer to some of these problems now as differences, but to be diagnosed with autism or ADHD, you must be impaired, which means you must have a disability of some sort. I think there's too much of a relaxation of that requirement of the diagnosis, so that people are getting a diagnosis without having the level of impairment that really deserves a diagnosis. It's the impairment that means this is not a superpower, this is a medical problem that causes serious difficulties in life. It troubles me that a medical concept was created to help a set of people who really need that help terribly badly, and that it is being co-opted by people who are not significantly impaired, who think they have a superpower. It trivializes disorder for the people who really need it.
And I suppose it also blocks certain treatments and revelations in treatment that could come if it was those who were suffering from the illness version of that rather than the kind of lifestyle version of that condition, because it skews the table.
100%. I mean, if you think now that the type of population that have autism includes Elon Musk and Anthony Hopkins, I have absolutely no idea what difficulties either of those men have to qualify for that diagnosis. But if you are including them in research studies along with somebody who's got the type of autism, which means they cannot function normally in education without support, well, then you've got such a heterogeneous population that the chances of you finding anything in common between these two groups of people is very, very unlikely. So we're really kind of muddying the pool of what autism is and stymieing research efforts.
It's a confused narrative as well, isn't it? Because it's about embracing difference often. These movements are focused on an idea of everyone is equal and should be treated as equals. And yet it's also an obsession with difference.
There's so many contradictions there, because I think, it does concern me that the kind of conversation that revolves around, let's say that you have an autism diagnosis at the mild end, and you say, well, I don't have a disorder, I have a difference. Well, that's fine. I'm more than willing to accept that the world is set up more optimally for some people than other people. And I'm more willing to accept that some people feel different or I don't understand how one knows that, but that there are differences and the world is not set up equally for everybody. But if you feel that the medical or that the problem that you have is difference and the fact that the world is not set up equally for you, then I don't think it's appropriate to co-opt a medical label to explain that. This medical label has been created to help a set of people who desperately need help. Instead, what we should be saying is, well, why is the world set up incorrectly or suboptimally for some people, better for other people? Let's look at social change. Different people learn differently. Can we accommodate that in schools? We should not need medical labels to do that.
And what happens when these numbers tip over, say, 50%? If more than 50% of any given school year believes themselves to be atypical, is that atypical anymore?
The stumbling block always with this diagnosis should be the impairment. So we have this sort of idea at the moment that, so for example, having difficulty standing up in front of, say, 100 people and doing public speaking can now potentially attract a medical diagnosis. Whereas I would say that, we should keep medical diagnosis for people who have genuine impairments and difficulties, and we need to have a better definition of what an impairment is. An impairment really should be something that any reasonable person should be able to do, and you can't do it because you have a problem. So, for example, if you have a teenager who just cannot go to school because of their whatever difficulty they might have, well, that's an impairment. Or if you can't do the shopping, or if you can't leave the house, these are impairments. And that's the line that we need to draw more clearly in the sand, because I think at the moment people have difficulties that they can overcome, and those difficulties are still attracting a medical diagnosis. But if you can overcome the difficulty, it doesn't really qualify as impairment. And I think it's very hard. Listen, the bottom line is nobody knows where illness begins and ends.
And you feel horribly unsympathetic to say to someone, look, just get over it.
Yeah.
It's these things, the kind of stoic, stiff upper lip stuff that obviously this is an overcorrection for. And it's difficult because, of course, even in these conversations, it's hard not to swing back too far in the other direction.
Yeah.
Perhaps it's a good time to talk about long COVID, because that's an example of something where I think there has been a lot of kind of stiff upper lip, just get over it kind of rhetoric from certain portions of society. Long COVID is a fascinating story. I heard you speaking about it the other day, and I just want you to recount the story of how it started as a concept, because just yesterday they announced 1/10 of people in England said that they thought they still have long COVID, which seems quite extraordinary given how far out from the pandemic we now are. So give us the story of how long COVID began.
Pandemic hit a lot of countries around sort of, for us, it was really March was our first lockdown. In Italy, it was February. But that's the sort of timescale we were looking at for the sort of beginnings of lockdowns, etc. And then in May, the 20th of May, 2020, concerns had been arising on social media that perhaps people weren't recovering as quickly from COVID, and these were mild cases who had not been hospitalized. There'd been a bit of a conversation like that on social media for a few weeks, and you've got to put that into context. If the illness started in March and you're already concerned about long-term symptoms in kind of April, May, you're very early
very few
to be
people
making
could have had
these.
it for that long.
Well, you're very early to be predicting kind of chronic illness for millions at that point in the pandemic. It wasn't unrealistic concern, but there was no indication at that point that that could happen. On the 20th of May, 2020, hashtag long COVID emerged from a single individual on Twitter. And that hashtag then drew together those people who had been having these conversations about potential long-term consequences for people, specifically with mild long COVID. And then with incredible speed, hashtag long COVID became a condition called long COVID, which entered the mouths of politicians, which then entered medical journals, mainstream media, with incredible rapidity. But before, there really had been time for scientists to examine, what is this, exactly? What are we talking about? The lore of long COVID spread much more rapidly than science could actually kind of examine what was happening.
It's amazing for someone who's, like I am, a naive layperson who was just completely oblivious to this at the time. My expectation was that long COVID was a condition that a group of scientists had come to understand that some people were suffering from, and then had made the world aware of, and then other people had perhaps connected up their set of symptoms to that condition. But the idea that it was actually downstream of somebody on social media via politicians taking it on as a kind of new social cause, then into the medical establishment. That is quite extraordinary.
Yeah. So there was a lot of people, we were all suffering in the pandemic, some of us less, some of us more so. Obviously, all our attention was on the dead and dying and the families of people who were losing loved ones. There was also a lot of our attention on, people losing their businesses, people losing their jobs. But then there was a whole bunch of other people in the middle who were also suffering. And it was quite hard to be heard, or you couldn't get hospital appointments and you weren't seeing other people and you didn't have the usual sort of support networks. And it was quite difficult to express your distress in that climate. When people are dying, how do you say to somebody, but I'm suffering too, if your suffering is not so extreme? And I think long COVID provided a very useful way for people to express distress and ask for help. But I think ultimately the science, it got ahead of the science. Long COVID undoubtedly has multiple different causes. So I volunteered in intensive care during the pandemic and I saw the worst of it. And I've absolutely no doubt that anyone who ended up in intensive care will have long-term symptoms. That will be one form of long COVID. There will be people who everything was caused by COVID, apparently, people with misdiagnosis because of the assumption that something was caused by COVID. There will be people who have chronic fatigue syndromes that occur after some viral infections. But the growing evidence now is that the largest group of people with long COVID actually have a psychosomatic disorder. So just to explain what I mean by that, so psychosomatic disorder, to me, I care for people with psychosomatic disorders, are very serious, they're unconsciously generated. It's not something done on purpose, it's not somebody complaining about nothing.
This isn't an attention seeker or a faker.
These are genuine symptoms that can be very, very disabling. First of all, the pandemic was a perfect storm for developing psychosomatic symptoms. So what happened in a pandemic? So we turn on our radio every day and it says 1,000 people died today. And now it says, now would you please examine your body for symptoms in case you're the next in the line for the dying. So now suddenly I'm highly anxious that I'm going to catch a disease which is very, very lethal. And I'm being asked to examine my body to see if I have anything wrong. The minute you examine your body for imperfections, or you'll notice your heart beating, you'll notice things. I mean, I thought I had COVID multiple times during the pandemic and I never once got it, but I was just so anxious and focused.
I thought I had brain fog for the whole pandemic, but it just turned out it was just my personality.
Exactly. So basically when, you've got anxious people, their bodies are activated by anxiety, you're telling them to examine their bodies, and also we've different diet, different exercise, social isolation. So lots of reasons to feel sick in a pandemic. And then you tell people there is this thing called long COVID and it's, you might barely notice you have COVID and you could get this thing. Then you're really creating a perfect situation for people to develop physical health, ill health by anxious inattention to the body. And as the science has had time to look at long COVID more closely, there are multiple pointers to there being a significant number of people for whom the problem was psychosomatic, and the type of pointers I'm talking about. A self-diagnosis of COVID was more likely to lead to long COVID than a proven diagnosis. Ironically, long COVID is more common in non-hospitalized people. So obviously, logically, you would think that, someone hospitalized has a more serious disease, they would be more likely to get long COVID. That's not the case. Psychiatric symptoms such as anxiety and depression put you at risk of long COVID. Loneliness has been repeatedly shown in several studies to be a predictor for long COVID. People who have an expectation of symptom severity, so if you expect that it will be hard to recover from COVID, you're more likely to get long COVID. So again, I want to emphasize that does not mean I think people aren't suffering. I believe they are, but I believe the mechanism is not necessarily always what people think it is, which means that the way to get better isn't always the way people think it is either.
And the context of COVID was unique, perhaps, in that we all know that post-viral fatigue exists, because if you've ever had a virus, you know the feeling afterwards. Yeah. But in that particular lockdown setting, when you are so isolated and so filled with anxiety, that seems like an absolute perfect storm for a lack of recovery.
Absolutely. And, it was just social isolation, I'm sure, had an enormous impact on people because, you've got a situation there where you have nothing but time to to be frightened and to think about what's happening to your body. Whereas normally, you have to go to work and then your mind is kind of diverted. And it's that kind of anxious attention to your body and that anxious attention to your symptoms that really reinforces them at times. Combined with the sort of misinformation, really, that, we're all being really terrified into this belief that long COVID was unrecoverable from. And I don't think that kind of helped people much.
Let's talk about maybe a little bit about these kind of psychosomatic situations, because I think to many people, the instant reaction is to say, well, look, there is this bucket of people who are making it all up. It's all in their head, to use a phrase that you use in your books. They have created something from nothing, effectively. And I think maybe that was a lot of pushback against Wes Streeting when he made that comment just this week about people who are out of work because of mental health diagnosis, especially because there's a degree of self-diagnosis there. How can we build a tolerant society for people with psychosomatic illness that you say is genuinely, can be devastating, as devastating as a kind of, quote, real physical illness, while also making sure people are given the expectation that they can recover from these things in a way that you wouldn't expect that of someone who has terminal cancer? How do we create that difference while also making sure that those people don't feel that they're being in any way kind of derided?
I mean, the first thing we have to do is we have to basically make people realize that this kind of mind-body connection is very powerful, and that psychosomatic, so I look after people with seizures. Everyone referred to me believes they have epilepsy, which is a brain disease caused by unwanted electrical activity in the brain. But at least a fifth, if not a much higher percentage at times, actually have seizures that have a purely psychological cause. So sometimes I think when you hear the word psychosomatic, people think minor symptoms and they think in your control. But actually the most severe disabilities I see are psychosomatic. But I have a great deal of difficulty convincing people that it's not a dismissal to get that diagnosis.
No one wants to be told it's all in your head.
No, because they think that that means you are doing it on purpose or you could control it. Usually I will try, to explain it to people, I'll give them kind of commoner things that happen to us as analogies. So for example, I'll say to my patients, well, if I was frightened now, my heart rate would be going very quickly. Now you wouldn't say your heart rate's going very quickly on purpose. You're doing that on purpose. You would know that that's an entirely unconscious reaction over which I have no control. You would never say to me, snap out of it. So these kind of uncontrollable things that happen to all of our bodies every day, they're so common. So why should they not, like every other medical problem, go wrong sometimes? And when it goes wrong, it is every bit as uncontrollable. However, like the heart rate example, you can see that perhaps if there are situations in which my heart rate goes too quickly and I have no control over that and it's not my fault, it's not a heart disease, but you can also conceive that perhaps with certain interventions, I might learn to control that in the future going forward. So a psychosomatic diagnosis shouldn't be seen as a dismissal. These are some of the worst illnesses with the worst disabilities. They're hard to conceptualize, they're hard to treat, they are very serious conditions. However, if we could accept them, a little like the heart rate example, we can teach people techniques that will help them overcome the difficulty that they have. And that's not easy, but it can be done. But it can't be done if we don't accept the reality of these problems.
It's quite radical. Do you feel any pushback, or in your experience, have you sensed that other doctors are hesitant to give a psychosomatic diagnosis?
Well, I was about to say no, but the bottom line is that, what I talk about, all doctors, not all doctors, because there's no such thing as such a generalization, but every single doctor in every single specialty, cardiology, asthma, respiratory physicians, dermatology, GPs, etc., we all encounter a lot of people who have psychosomatic symptoms. And we all take them, or well, we don't again all take them, but most of us take it very seriously and it concerns us. And if we give a psychosomatic diagnosis, we're not giving it as a dismissal, we're giving it as an explanation in the hope that somebody can see a different kind of strategy to get out of this situation. But we are also a little bit frightened of giving that diagnosis at times, and we're frightened because it upsets people and because it is immediately misunderstood. It's immediately misunderstood as meaning your pain is less painful, your paralysis is less paralyzing, your fatigue is less fatiguing. I guarantee you the fatigue that comes with a psychosomatic disorder is every bit as bad as a fatigue that comes with a physical problem like cancer, for example. And yet the minute you say it's psychosomatic, people think that they're being told that what they're feeling isn't real and that it's in their control. But I think doctors do need to be a little bit braver about sharing these suspicions with people, even though it can be upsetting to people. It's how you break the news. You need to let people know that, you are not invalidating their suffering. You are just offering them an alternative way forward. I think it's important for mental health conditions. I think sometimes when we frame them in a very biological way to do with chemicals and so forth within the brain, it gives people a little bit of relief because it makes them feel that something is not their fault, but it also inadvertently takes control away from them. You cannot necessarily change the chemical structures of your brain. So I would encourage people with mental health problems to think, well, what can I change? And your mental health cannot be kind of extricated from your social environment or your relationships. And those are areas that are available to us to think about. So I find biological explanations for mental health problems sometimes can entrench symptoms, and I would encourage people to think more socially and environmentally when it comes to those problems.
Mm-hmm. Before we run out of time, I just want to ask you about the kind of solutions to this problem. Mm-hmm. So we've got this overdiagnosis issue that you lay out in your book. Wes Streeting has pointed out the mental health overdiagnosis issue happening. His response to that might be to say we need to cut certain degrees of welfare for people who claim a certain amount of time off work due to mental health. What do you think would be the solution here to this overdiagnosis crisis?
I think, first of all, if we take first what we spoke about with physical disease, so for example, blood pressure, cancer, all these type of things, and rather than having kind of cancer blanket screening programs that target everybody, if you take hypertension as an example, that's super low value care to screen everyone and to prevent one stroke, treat, 80, 90 people. That's low value care. What you can do instead is screen high-risk people. So you need to capture the people at highest risk of disease, which is often people in deprived areas or from underprivileged backgrounds. So that way you're getting high-value care because you are targeting the correct people. So I think with physical health, we need to do a better job of targeting the correct people and avoiding turning too many healthy people into patients. With regard to mental health problems, I think that I'm not in any way advocating for a snap out of it policy or a let's go back to how things were where we didn't actually care very much about struggling people policy. I'm very much in the camp of saying that mental health is just completely intermingled with your social environment and your social well-being. So I'm advocating for better lives for people. I'm advocating for when it comes to in schools, recognizing struggling people without having to give them medical labels. You should be able to go into a school and say, this kid is not happy and I'm worried about them, and you should not feel that you have to tell them their brain is neurodevelopmentally abnormal just to get them help.
Suzanne O'Sullivan, thank you very much.
Thank you.
So that was the very in-demand Dr. Suzanne O'Sullivan. The Age of Diagnosis is her brilliant book, which I would heartily recommend to you all if you're fascinated, as I am, in questions of overdiagnosis, the medicalisation of everyday life, and the ways in which we could treat those with a bit more dignity who might have psychosomatic illness. I hope we can have her back on soon to talk perhaps more about those particularly COVID-related issues that we touched upon briefly in the middle there. So do stay tuned for that in the future, and also for our special documentary with Jay Bhattacharya. Thanks for watching.